Good afternoon, everybody, and welcome to the Department of Medicine Research and Innovation Conference. My name is Sonia Flores, and I am a professor in the Department of Medicine. I'm also the Vice Chair for Diversity and Justice, and I will be moderating today's sessions. And our first speaker will be Ms. K.Bowden, who is an assistant professor in the Department of Medicine, and she's also the Associate Division Head of Hospital Medicine and the Medical Director of the Care Clinic in the Division of Oncology. Ms. Bowden obtained her BS in nursing from the University of Kansas, her Master's of Nursing degree from Georgetown University, and her postmaster's certificate as an adult geriatric acute care nurse practitioner here at the University of Colorado. Her career has focused on improving the delivery, quality, and experience of healthcare through development of innovative care delivery models. Her efforts to reduce unplanned acute care utilization through providing advanced urgent care services to oncology patients gained national attention and has been replicated at numerous institutions. So again, she developed this model that other institutions have adopted. She also developed and published a conceptual framework which guides the COVID-19 response for the Division of Hospital Medicine. She's also an advocate for APPs in the DOM, and several years ago, she won a DOM Pathfinder Innovator Award. Very well deserved. And today, she will describe the care clinic efforts which she has spearheaded. Take it away, Ms. Bowden.
Awesome. Thanks so much for that very lovely intro, Sonia. I will pull up my presentation here, and thanks everybody who is in attendance today. All right, this is showing up okay. I'm gonna go with yes unless I hear otherwise. So like Sonia said, my name is Casey. I'm a nurse practitioner in the divisions of oncology and hospital medicine. And today I'm here to talk with you a little bit about the Care Clinic, which is an innovative model to improve the value, delivery, and experience of oncology care. I wasn't sure what my audience would be today, and I was wondering if it was going to be more science-based. As a person whose background is in hospital medicine, and that my kind of area of interest as it pertains to scholarly work and publications is system-based, I wanted to kind of align some of my presentation today to perhaps more science-minded people, or bench science-minded people, I should say. But so just some background information just about oncology in general. The overall death rate from cancer in the US is declining pretty dramatically, 29% from 1991 to 2017, including a 2.2% drop from 2016 to 2017. And this is amazing, right? This is because of our advances in science in oncology and cancer care. However, while the annual rates of new cancers and cancer deaths, while the rates are decreasing, still the number of new cancer diagnoses as well as cancer deaths are increasing as a result of our growing and aging patient population. So, you know, we are doing a great job at identifying and helping patients to live longer, but that number of patients is actually still growing. And a little bit more background on what that looks like for people in the throes of you know, getting a diagnosis and treatment for a cancer diagnosis. So on average, patients that are receiving chemotherapy have 1 hospital admission and 2 ED visits per year. 50% of those ED visits and 40% of admissions are directly related to treatment toxicities, so side effects or toxicities related to your oncology treatment. And single center studies have, for patients receiving chemotherapy, have shown 30-day readmission rates of approximately 22 to 27% nationally, compared to an all-cause readmission rate for, you know, non-oncology patients. We tend to think about closer to 9 to 12%. The long and short of this being, you know, this is a very high rate of readmission rate for a patient population. And these acute episodes have a lot of downsides, including reduction in patients' quality of life, delays in their oncology treatment, increased risk for infections, increased costs, and of course, burdens on caregivers. And I talked a little bit about cost, but going into a little bit more detail about that and the cost of cancer care. And the long and short of this, they're like the big message here is that it is exploding. The cost of cancer care the trajectory is rising absolutely rapidly. So in 2019, cancer care in the United States cost more than $150 billion. It's projected to exceed $245 billion by 2030. And for patients with advanced care, acute hospitalizations account for 48%, so almost half of their total cancer expenditures, and 67% of regional spending variation, which I'll talk about a little bit at a later slide. For a chemotherapy-related admission, an average cost of hospitalization is $22,000, although this was older data, and so this is actually likely increased since then. And the average inpatient cost for in the month before death is over $20,000. And this chart on the right, on this graph on the right, you can kind of see for oncology patients what the cost is as it pertains to the months before death, and how for acute inpatient costs, there is a drastic rise in the overall costs in those months directly before patients before death. And how does that actually impact the patients directly? Right. So okay, so we know it costs a lot for the system, but how does that impact the patients? Well, 63% of patients report experiencing financial struggles after a cancer diagnosis. In 2019, the national patient economic burden associated with cancer care was $21.9 billion. This was made out of out-of-pocket costs of $16.2 billion, and then time associated costs of $4.87 billion. So this is the direct cost to patients, either out of pocket or just in lost revenue based on time and time toxicity, is astronomical. About half of patients, 49%, report travel to and from their appointments as a financial burden. And the overall cancer mortality rates are 12.3% higher for patients living in counties with persistent poverty. And this makes sense, right? Because what I'm telling you is that patients are living longer, but they're incredibly high utilizing. And that really works. In order to experience the benefits of living longer, those patients are needing to receive more and more treatment. They're needing to be physically present in and at a hospital more often. And really, this tends to work best for an affluent urban dwelling person. So while patients are living longer, it's actually widened disparities in outcomes in cancer care. So overall, what has this resulted in? Like I said, we have a gap now. The science of cancer has outpaced the system. The science has allowed patients to live longer and for more patients to survive. However, the system has not been built to accommodate that. Essentially, we've created another, just like we think of our aging population, our oncology patient is a very parallel community. Our cancer patient population is very parallel, right? Because they are rapidly growing because of advances in science, and that's an amazing thing. They are also high utilizing and have high needs. And so suddenly you have science that can allow them to live longer, but a system that lags. And the gap between that system is filled with things like financial toxicity, time toxicity, increased symptom burden, and widened healthcare disparities. And so what we need is a merging of this. The system needs to catch up to the science. I talked a little bit about acute hospital care and regional spending variability, but again, as I look more in depth into the costs associated with cancer care, I wanted to call out once again that for advanced cancer, acute hospital care accounts for a massive amount of the overall cost. So 48% of spending, and then 67% of regional spending variation. And what this is looking at the spending on acute hospitalizations throughout different regions. And what they see is that that variation is really, really wide. If we see that variation is incredibly wide, what that actually tells us is that if we provide better, is that there are places that are providing better care that is resulting in those patients not needing to be in the hospital as much. So what has that resulted in? So CMS, or Medicare, Center for Medicare and Medicaid Services, has looked at all of this information. They look at the information of saying these costs are going up drastically. However, clearly places are showing us that they can put measures into place that could keep people out of the hospital. And we know that hospitalization is a massive portion of the cost with this patient population. And so their response to that has been to identify 10 conditions for hospital visits among patients receiving systemic chemotherapy that are being considered potentially preventable through appropriately managed outpatient care. And so this includes things like anemia, dehydration, nausea, vomiting, diarrhea, neutropenia, fever, pain, pneumonia, sepsis. If you have done any work in admitting or in the acute care of oncology patients, you likely know that these are all the things we are always admitting oncology patients for. So as far as being considered potentially preventable, this is an eye opener for those of us on the inpatient side, because these are typically the things we very frequently are admitting oncology patients for. As a result of this, starting 2022, hospitals might actually be financially penalized if patients that are receiving outpatient chemotherapy visit the emergency department or admitted to the hospital for these preventable conditions. There's a lot of kind of policy work and things going into this right now, which is kind of why I put an asterisk on this, on what the reimbursement changes will be. But the big take home message is that CMS is kind of honing in on this acute care utilization and preventable ED visits, preventable hospitalizations in this oncology patient population in a way that will directly impact reimbursement to healthcare systems. And as a result of all that, the reduction of unplanned acute care is a major priority for clinical oncology. And one study, their take home was that our analysis suggests that the strategy with the greatest potential to improve the value of care for patients with advanced cancer is to reduce the reliance on acute hospital care for this patient population. So the paper came out in 2018 that was published in the Journal of Oncology Practice, and it looked at what are the best practices for reducing unplanned acute care for patients with cancer. This is a review of PubMed articles from 2000 to 2017, as well as published guidelines from national organizations. And they found essentially 5 strategies to reduce unplanned acute care. Identifying patients at high risk for unplanned acute care, enhanced access and care coordination, standardized clinical pathways for symptom management, development of urgent care tactics, and early use of palliative care. And this is where I want to introduce you to the University of Colorado Care Clinic. And the Care Clinic, we are a multidisciplinary clinic. We're dedicated to improving the quality, value, and experience of cancer care through proactive and patient-centered approaches to advanced symptom management and urgent care that's tailored to the unique needs of oncology patients. So what are the things that we can do in the Care Clinic? So the clinical mission, urgent care tactics. We can essentially do anything that's done in an emergency department, including labs. We could labs, infusions. We can do IV fluids, blood products, IV pain medications, IV antibiotics. We can do all modalities of imaging same day, including X-ray, ultrasound, CT, MRI. We can do procedures, including paras, thoras, and lines. And obviously, we have a lot of patients that have symptomatic malignant ascites and malignant effusions. So this is a tremendous value to those patients. And we also have consultative services and collaborative teams in the primary oncology teams, the diabetes educator, and palliative care, nutrition, and social work. So in line with that goal of, so I took over as a medical director in Care Clinic in July of 2019. And, we really wanted to focus on kind of this paper and these strategies for reducing unplanned acute care. And, our role in that, where we started, was very much this idea of what do we do to, that development of urgent care tactics and make that really good. So we put together a collaborative model using hospital medicine oncology APPs, noting that a lot of these are internal medicine issues impacting oncology patients, and that hospital medicine APPs are well equipped and trained to understand some of those more advanced issues in oncology patients. We increased our coverage to 7 days a week. We added the procedural services, like I said before, so we can now do those in the clinic. And traditionally, those were either being sent to IR with usually a 7 to 14 day wait time, or those were being done in the ED. We've incorporated point of care ultrasound and have worked on getting our APPs trained in either point of care ultrasound for procedures or diagnostic point of care ultrasound. We've optimized our staffing to ensure that we're able to meet our growing patient volumes, expanded our capacity, which I also put an asterisk on because this is actually a big challenge for us. And I think one, we have room for growth, but we have room for, there's opportunity, but we did add some capacity. And we have really worked on optimizing our patient population and outreach so that we can increase our patient volumes. So just in the last year over year, we've had a 40% increase in total volumes. And we had a near like 20% in the year prior to that. So in the last couple of years, we've had really tremendous growth in our overall volumes. And so this was in line with this, how do we try to, that development of urgent care tactics. However, when we looked at the ways that you reduce unplanned acute care and embracing the spirit of this, that's only one piece of it. There's all these other tactics, including, the identification of high-risk patients, enhanced access and coordination, standardized clinical pathways, and early use of palliative care. And we really wanted to embrace this idea and this idea of both value-based care and how do we how do we expand what we are doing in care clinic to really get at this aim of how do we keep patients out of the emergency room, out of the hospital while they're undergoing their cancer treatment. And we made a goal to shift from a more reactive approach. So, we optimized the way that we provided those urgent care services, but it's still reactive. It requires a patient to have a symptom, have a problem, and then, and then come into the care clinic. Our goal and where we're really applying a lot of this innovation is how do we make that shift from reactive to proactive approach? And we really are embracing this value-based care model and really trying to, so our goal in this is integrating the different components of oncology care, breaking down silos and making care more comprehensive, patient-centered, and accessible. And that's through use of things like, we have, of course, the primary oncology clinic, which, they drive a lot of the care for these oncology patients. But by enhancing things like patient navigation, early use of palliative care, improved acute care tactics such as the care clinic, optimizing things like supportive care and our partnerships with primary care so that patients are getting appropriate supportive and primary care and aren't going to the ED for things like DKA or uncontrolled hyperglycemia. And then also incorporating things like innovative technologies like remote patient monitoring, use of telehealth or home care models, and then optimizing our data and analytics. And here's just an example or kind of a running list of all the different things that kind of started in this small little care clinic, which I think started more as a concept more than it did anything else. And all these ways that we are trying to achieve this aim of how do we improve the value of oncology care for cancer patients and how do we break down these silos. So we've done things, we added an RN navigator and a PAL care nurse navigator. I just want to touch on a couple of these just partially for the sake of time, but our PAL care or our nurse navigator has created a project, for example, where she does outreach to any oncology patient that visits the ED. She sends them a My Health Connection message saying, hey, I noticed you're in the emergency department. Wanted to let you know about our clinic that exists. We're available if you have issues. And then also messaging their primary team, because we recognize there was a gap in the primary teams, even knowing that their patients were in the emergency department, and then offering them either close and early follow-up in the care clinic, or, if they want to see the patient within 1 week. We've also created pathways for patients getting discharged from the hospital to try to have patients admitted for symptom-based complaints seen within 2 to 3 days of discharge, or at least within 1 week, again, to try to prevent those readmissions for those reasons. We added a PAL care nurse navigator, and we are piloting different models to have earlier integration of palliative care and early advanced care planning conversations, as well as pilots in all the clinics to improve documentation of MDPOA and advanced care planning. I talked a little bit about developing our data dashboards. We also added a resident education component, in part so that we can teach residents about these new and emerging models and about things like value-based care, because I think this is all the direction healthcare is going. It is leaving the four walls of the hospital and saying, how do we provide high quality but high complexity care that does not need to be in the four walls of the hospital? And then we've created really interesting partnerships with places with ASCO and other payers like Anthem, and are participating in pilots nationally to embrace this kind of oncology, medical home, and value-based care model. So I talked a little bit about here, what we've done, but how effective has it been? So since July of 2019, when we look at this chart here at the bottom, is just patients seen in care clinics. So not all comers to the cancer center, just care clinic. But specifically looking at, this is over 6-month periods, over the 30-day potentially avoidable ED visits, we've been able to reduce those by about 50%. So we started out at a rate of 10.3% of 30-day potentially avoidable ED visits. We've reduced that down to pretty consistently in the 4 and 5% range, in spite of higher patient volumes and higher complexity of patients. And 40% of our patients say, about 39 to 40% consistently say if we weren't available, they would go to the ED for whatever their complaint was that day. Over the last 6 months, we've seen a consistent decrease. So this is for the cancer center then as a whole, but an overall decrease in patients that have preventable emergency department or inpatient visits, as well as an increase in patients that do not have an emergency department or inpatient visit, particularly those preventable visits. And when we look at how care clinic or how the CU Cancer Center compares actually to the system, to the UC Health system, you can see that we actually do a better job, particularly at this reduction of preventable or at keeping the number of preventable ED visits compared to our community partners, in spite of the fact that we have a larger and higher complexity patient population. So over the last 6 months, our preventable ED visit rate is at 6.2% here at Anschutz and 6.5% in Denver Metro, compared to 7.9 and 13.1% in North and South. And more than that, we've also provided our patients with a really great experience. So this is just an example of feedback that we received from a patient's family actually a year after they passed away. And they sent this with a kind of a goodie basket to care clinic and said, today's the 1-year passing of our family member, and we want to thank you, those who supported and cared for him. Thank you for being a light in the darkness. We've told countless people we don't know what we would have done without the care clinic. We hope you know how much it means to our family to have been able to have your clinic as support. And some other really positive patient feedback that we get. This is a model. It is patient-centered. And in spite of being actually in kind of a small, dark space and was seemingly not optimized, the patient-centered approach to it speaks to patients and they love it. Once they discover us, they make a point that they utilize care clinic as opposed to the emergency department. And so everybody wins. The patients are getting high quality care. It's at a lower cost to them, and it's decompressing, our emergency department for patients that really need to be in there. As far as future directions and innovations, our goal is really to continue to grow, expand, and optimize this model, and then to disseminate to other patient populations or disease sites such as COPD, heart failure, or transplant. So goals of expanding to 24-hour services with continued partnership with like emergency medicine, hospital medicine, oncology, expanding to other subspecialties, continuing to figure out how we incorporate primary care, palliative care, supportive care. So we're placing a big emphasis on palliative care this year, and how do we work to integrate palliative care early on, again, breaking down silos actually that exist between oncology and palliative care, even though there should be so much overlap in those two worlds. A closer integration of the science and the system. One thing for us is like immunotherapy, the development is rapid and it's incredible what it's doing for patients, but making sure that we have evidence-based pathways for how do we manage the toxicities and the complications and side effects, especially when symptoms from immunotherapy related toxicities overlap with symptoms patients can have related to their underlying cancer or chemotherapy and things like that. So trying to understand emerging science and then build systems that will meet where that science is going, and it doesn't lag behind, kind of like the place we're in right now. And then tons of room for innovation. So we're starting a new remote patient we did a pilot in remote patient monitoring last fall. We're starting a new one this spring or this summer. And we're actually finalists in the Shark Tank competition and have a team that's going to go through IHQSC. hopefully optimizing use of technology, predictive analytics, and looking into more home-based care delivery models. And then, like I said earlier, expanding this to other patient populations. With that, I will wrap up. I think I'm just a couple minutes over and take any questions. And thank you for listening.
Thank you so much, Casey, and for a fascinating talk. I don't know. I mean, I think about this. My father died of colon cancer about 10 years ago. And honestly, this would have been a tremendously helpful having access to something like that. So along those lines, and I don't see any other questions. Oh, yeah, there are some questions. So there's a question here is, have you considered a way to capture the variability in care attributed to traditional acute care? It seems care clinic is a shift to more specialized oncologic care, but may not actually cut down on emergent visits or hospitalizations, as your data seem to show.
Okay, let me work through this question. Have you considered a way to capture variability care attributed to traditional acute care, more specialized, but may not actually cut down on emergent visits or hospitalizations? Okay, I think I'm a little bit confused as about the question. Let's see. More specialized in oncology, or it may not actually cut down on emergent visits or hospitalization. So I guess the best answer I can give to that, as far as variability in care, is that you are correct in that the capturing of good and accurate data as far as the effectiveness of a program like Care Clinic is complicated. And it's complicated for several reasons. One, you're right that the patient population we are going to see in Care Clinic is sicker than the average overall like cancer care population, right? Like there's a high percentage of patients who actually live very well and don't need any acute care services throughout the duration of their oncology treatment. The people we are seeing tend to be, I mean, it was on one of those slides, but over 50% of our patients are advanced GI. So patients with the highest morbidity, highest mortality, and that complicates our data. The other thing that complicates our data is our size. Right now, we're a really small clinic with only, 4 beds and 2 chairs and maybe access to 2 more chairs. And we're looking at a cancer center that's, 10 to 15,000 plus patients per year. Scoping that is quite complicated. So when we try to build our data dashboards, that's why I look at when I look at our 30-day ED visits of patients we are seeing in Care Clinic, that's because it's at least a direct measure of how are we doing with the care we provide, and are we were we successful in reducing those 30-day ED visits of our patient population, because that group is overall smaller. The other reason it's hard is because other things people will look at for models like Care Clinic is like, oh, are you reducing inpatient length of stay? But one complex thing about that is if we are actually reducing total inpatient admissions, because we're taking on the patients with like nausea, vomiting that would have gotten admitted and been there for 1 to 2 days, but we're able to take those on in Care Clinic, the length of stay actually can look longer. So we have seen an overall decrease in inpatient oncology volumes, but hard to say if we attributed that to like increased volumes in Care Clinic and we're offloading some of those patients. It's really hard to establish causality. So I do think, like, as far as your question, it also gets at these value-based care models. One of the most complex things in them that like it differs them from fee-for-service models is it's really hard. Like the data collection and showing effectiveness there are a lot of complexities and nuances to it. And that model, and therefore like the financial argument for the model, and that you're trying to make an argument for a cost avoidant model, it can be a lot more complicated.
Thank you, Casey. And I was very pleased to see that you have also incorporated patient navigators in the model. I mean, I know that many cancer patients, including my father, he just stopped eating. He wouldn't eat at all. And I think that's eventually what killed him, because his bone marrow wouldn't respond after the conclusion of the therapy. So, having that incorporated in the home care model, I think is important. So thank you so much.